everyone. My name is Laura Bonilla, and I am the Maryland ROTA Project Coordinator. We are pleased to welcome you to this webinar on prescribing buprenorphine via telemedicine to underserved areas. Maryland ROTA is part of an initiative by the Substance Abuse and Mental Health Services Administration, established by the University of Maryland in partnership with local and state organizations. Our project aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the opioid misuse epidemic. Our multi-pronged approach includes delivering evidence-based training, providing current information and education, and strengthening youth against opioid misuse. For example, we encourage you to join our ROTA network to learn about the best practices, ask questions of peers and experts, and share your local experiences. More information about Maryland ROTA and a link for joining our network are available at www.marylandrota.org. Today, we are excited to be joined by our presenter, Dr. Eric Weintraub, Associate Professor of Psychiatry, Director, Division of Addiction Research and Treatment with the University of Maryland School of Medicine. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentations. Please do not raise your hand. Instead, we ask that you please post your questions in the Q&A box. We will hold a Q&A session after the presentations. We will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar will be made available on our website, www.marylandrota.org. You can find the webinar page under the Services tab. Thank you, and we hope you enjoy this webinar. Dr. Weintraub, I'll hand it over to you.
Thank you. I'm just going to put up my slides here. So my name is Dr. Eric Weintraub. I'm here in Baltimore, Maryland. Thank you for having me, Laura, and welcome everyone. I want to cover an area about prescribing buprenorphine or medication-based therapy to underserved rural areas. This is an area that, or space that we've been working in for the past 5 years, even prior to COVID. And I want to go over 3 major topics. One is to kind of give a brief background on the opioid epidemic with a focus on issues impacting rural America, talk about what's available, its effective evidence-based treatments in individuals with opioid use disorder, and talk about some of the barriers to accessing these interventions, especially those especially in underserved rural areas, and talk about some of the current telemedicine interventions. And we'll talk about a mobile unit that we've developed that we're utilizing on the eastern shore of Maryland to help with our help patients with opioid use disorder get engaged in treatment. So just real briefly, rural demographics. A large part of the U.S. Landmass has very few of its population. So rural areas cover 97% of the U.S., where 60 million people live, and 9% of the population, or approximately 5 million, live in very, very rural counties. Rural Americans tend to be a bit older, are less likely to have a college degree, and have lower poverty rates. This is a SAMHSA table that was published in 2016. What I want you to look at basically is that substance use rates are not that different, especially when it comes to the misuse of opioids, and we'll get into a little bit more detail between non-metro, small metro, and large metro areas. There's a little bit more alcohol use and cigarette smoking in rural areas, and a little bit less of cocaine use, and a little bit less at sometimes over the last 20 years of opioids as well, but it's pretty close. So there are big issues there. In 2006, the rates for rural areas for overdose deaths surpassed those of urban areas, and that is per capita rates, not total rates. So in 2015, the rural rates of overdose deaths were about 17 per 100,000 versus an urban rate of 16.2 per 100,000. This was a huge change from the 70s and 80s when a lot of hard drug use was centered, especially opioid use was centered in urban areas. That has now changed where the urban rate has gone up in the last couple of years, where it's a little bit higher than the rural rates, but the rural rates are still very high and much higher than they were 30 years ago. As you can see in the third slide, the rates from 1999 to 2015 in rural areas increased by over 300%, which is just astronomical. And what we're going to see is that rural areas didn't have the infrastructure to handle this increase in drug use and subsequent overdose deaths. Majority of overdose deaths we know occur at home, and in rural areas you have longer transport times for EMTs. You have a lack of public access to EMTs, especially for individuals in remote rural areas. And you have an increased number of basic EMTs who cannot give naloxone. This is a map from the CDC. I believe this is 2017, which shows the rates of overdose deaths in different parts of the country. And what you can see is the blue, dark blue is where the rates are very, very high. You can see that the Rust Belt, the Northeast, and then there's other different spotted areas where the overdose rates are high. And what this shows is that it's not consistently high in all areas of the country. So not all areas were equally hit, not all rural areas were equally affected by the overdose epidemic. And there's a lot of literature and books that you can read that talks about the development of this excuse me, problem across the country. This is a theory that was put forth by two Princeton economists, Ann Case and Angus Deaton, who talked about the mortality rates and labeled the concept deaths of despair. They showed that there were increasing death rates in middle-aged whites from the age of 45 to 54 between 1999 and 2014. And what I don't show is, sometimes I have a slide that I do show that this is atypical. In fact, not only atypical, we're the only industrialized society that showed this increase in death rates in middle ages. And for 2 or 3 years, I believe it was 2017, 18, and 19, we actually saw a decrease in life expectancy in the United States because of these issues. So what they found was that overdose deaths were impacting whites without degrees, and they related to a worsening labor market as they examined the labor market in rural areas and determined, I think this was already known, but they connected it to these deaths of despair by saying that the labor market and economy in rural America had really deteriorated since the early 1970s, when rural economy was at its strongest, where there were more unions, more industries, and between mechanization, urbanization, and globalization, we've seen a crumbling in the rural economy. And for those that live in rural areas or those that travel through rural areas, you can see some towns which had a industry or factory that's closed down, and the town has withered to some degrees, that lost their labor ability to for their individuals to find employment. So as a result, they saw an increase in deaths in these areas, and that were related to suicide deaths, overdoses, and alcoholic liver disease. And they labeled these as deaths of despair. So with the opioid use, epidemic, there is one other thing I want to talk about. I don't have the slide up here, but there was a three-pronged reason, or three different surges in opioid overdose deaths in the country. Starting in the late 1990s, what we saw was an increase in opioid prescribing by physicians. I mean, most of us are aware of the circumstances of this. Some long-acting opioids were created certain doctors started pushing that the patients had the right to get opioid medications to treat their pain. We saw a push by pharmaceutical giants to target doctors. A lot of these doctors were family practitioners that lived in rural areas to increase prescribing. It was almost considered a right for patients to get appropriate pain management, which they considered was opioid treatment. And the focus was on non-malignant pain. Prior to this, and when I actually trained, opioids were reserved for acute pain. For example, if you had an accident and had to go to shock trauma, you would get opioids. Or if you had cancer and you had terminal malignant pain, then you would get opioids. Otherwise, we were taught to be wary of using opioids. That changed in the 90s. People were trained that it's okay to prescribe these. There were studies that were poorly done that said that only less than 1% of the population would become addicted if you used prescribed opioids, and that turned out to be very untrue. We saw a burgeoning in opioid overdose deaths. Around 2010, we saw a surge of heroin come into the country, and it was coming from South America, and it was cheap and plentiful, and we saw an increase in heroin-related deaths. And what we've seen in the last 4 years is just a quick, steep incline in deaths due to synthetic opioids, mostly fentanyl and variants of fentanyl, that are being transported in from Mexico and China. And these synthetic fentanyls are extremely potent and deadly. And in many areas of the country, including Baltimore City, we don't even see heroin anymore. Everything that is bought by the people on the streets is really fentanyl, and there's really no way for them to know what they're buying and how potent things are. So what can we do about this? So there's a variety of different types of way of approaching treatment of opioid use disorder, but the one evidence-based treatment, and in this medication-assisted treatment is really a sort of an older term. We're using medication-based therapy now because we don't believe that medication is assisting other treatment, but it is really a mainstay of treatment. We have very, very strong evidence, and I'll talk a little bit more about this in a minute, that medications for opioid use disorder, and there's 3 that are approved by the FDA, methadone, buprenorphine, and now naltrexone, which comes in a longer acting variant called Vivitrol, are quite effective in helping patients with opioid use disorder. And in fact, of all the different substance use disorders, the medications for opioid use disorder are the best, the most studied, and we have the most evidence for them. We do have medicines for tobacco addiction, which are, I'd say, okay. We do have some medications for alcohol use disorder, which are okay. We really have no medications for stimulant use disorder, the different stimulant use disorder. So this is a quote by Michael Botticelli, who was the White House drug czar under Obama, and he made this comment: access to medication-assisted treatment can mean difference between life or death. And just as a aside, the World Health Organization has determined these medications to be essential medications. There's actually a world court case in which somebody that in Germany that was not hospitalized, but incarcerated, wasn't given methadone. He sued, and it was determined that he had the right to have his medication in while he was incarcerated. So here are U.S. counties lacking any publicly available medication for opioid use disorder as of 2017. And what you can see is that the coasts tend to have more treatment, and Middle America tends to have less. And some of the areas that are in the middle of the opioid epidemic are in red, which are the areas without any publicly available medication option, which is a big problem because again, the areas which are being most impacted sometimes have no treatment. And you can see that it's true in West Virginia and Kentucky. So why is that? Well, less than 5% of methadone programs are located in rural areas. And the reason that is, there's a couple reasons. One is that, as I had mentioned before, heroin addiction was generally an urban problem up until the mid-90s, late 90s. So there was no reason to have any methadone programs in rural areas. That's number one. Second one is that when methadone programs were first started around 1970, right before that, there was some misuse of methadone by prescribing physicians. They were called methadone doctors. So the programs are highly regulated by the federal government, require frequent attendance and daily dosing early in treatment, which is problematic in rural areas where transportation and travel times are a huge issue. And I'm going to get into that a little bit more. And again, for those of you in rural areas, you're aware of that. And again, because of the lack of methadone programs that are in rural areas, people that were interested in that have long wait lists. So I'll give you an example. We do a lot of work on the Eastern Shore of Maryland, and we were kind of going through the whole Eastern Shore about how many methadone programs there are, and we're aware of 2 in Talbot County in the Easton area, and at least one in the Salisbury area. There may be more, but all the other counties in the Eastern Shore do not have methadone programs, so that's just not available. Here's a map of U.S. buprenorphine providers. So I didn't put the slide up, but to become buprenorphine was approved around 2000, and it was to provide office-based treatment for patients, so they could go to a doctor's office to get a medication for opioid use disorder rather than going to a clinic. And to be able to prescribe buprenorphine, a physician has to get a waiver, which means he has to get extra training to be able to prescribe the medication. This is the only medication that I'm aware of in medicine that has to be done with. And really, buprenorphine is a very safe medication. So there's doctors that are prescribing all sorts of lethal and toxic medications, and not only, to help patients because there's a therapeutic indication if you use them correctly, but they're not able to prescribe buprenorphine unless they get the special waiver. So it's a barrier preventing physicians from engaging patients in treatment. There is clear evidence that has been gathered since 1970 or the 1960s when methadone came to the market that showed that both methadone and buprenorphine are more effective than no medications at all in a variety of areas. The primary outcome measures are they keep people in treatment, they decrease overdose deaths by up to 50%. Some studies even show higher rates of decrease in overdose deaths. They increase social functioning, they decrease criminal activity, they decrease needle sharing and spread of infectious diseases. And this is, there's no argument or debate. This is science. So if you believe in science and follow science, these medicines are critical to patients with opioid use disorder or getting better. There's studies that show that if you put people together in a study and somebody started on buprenorphine and maintained on it, about 50 to 75% will be in treatment within a year, and 0% of those that were taken off the medication or detox are still in treatment. So what are the clinical goals that we have? So over the years, we've been working in Baltimore City with people with opioid use disorder, or I have since I became a med student, because it's always been a big problem. Baltimore at one time was known as the heroin capital of the country. It's a port city, and heroin would flow through our city. So we've been dealing with this affliction for many years. So we've learned that you got to get people in the treatment right away. You got to have availability, and you can't give an appointment in a week. If somebody's using opioids 6 times a day and you say come back in a week, you don't know where they're going to be. So if they show up, you got to try to get them to treatment as soon as you can. So, and that includes expanding access to treatment, whether that means more methadone programs, more access to buprenorphine, and I'm not at all saying that counseling and recovery services are not important. They are, because it's hard to get well when you don't have a place to stay, you don't have any money, and so there's a combination of services that are necessary for people to improve. We've learned that our patients do better when they are able to access medical and mental health services alongside their addiction treatment, and recovery services, like I said, helping with housing, transportation issues, all those different social determinants of health, jobs. Those things are important as you begin to stabilize. This is something I picked up in Missouri, the state of Missouri. I was doing a talk there, and it turned out they're not a non-Medicaid expansion state. I'm not sure if that's still true, but at the time I was there, they weren't. And they had to be very careful with their funding. They had a very smart young woman who ran their opioid programs, and she came up with something called the medication first model. And this is a model that I believe in, so you can read through this, but the 4 main points were that you get people with OUD and they get pharmacotherapy as quickly as possible prior to lengthy assessments and treatment plannings sessions. Sometimes somebody has to sit around while they're in withdrawal for 4 or 5 hours to do an intake, and it's just not, it doesn't work. They leave, they become upset, they become frustrated, and then they're accused of acting out when they're just really feeling sick. So we give maintenance pharmacotherapy without arbitrary tapering or time limits, so we don't worry about the dose or how long they're on it. We just, I learned in medical school that we're always looking for the lowest effective dose, but effective is critical. You don't give somebody a medicine and don't give them enough of it to make it work. And then individualized psychosocial services are continually offered but not required as a condition of pharmacotherapy. I think this is the one probably where it would cause the most debate. But the question is, I think where I come on this issue is that a lot of times people are forced, and everybody's forced into the same kind of treatment, and that's not patient-centered treatment. Everybody's got to go to IOP. Everybody's got to do that. Well, that's not individualized. So if somebody's holding on to a job that's really critical to them and it's keeping their family and their house, and he's able to keep his house, well, you can't have him come to 10 or 12 hours of therapy and he's going to lose his job. So that, and make that a contingent on his being able to receive medication. And then the other thing is pharmacotherapy is discontinued only if it's worsening the person's condition. We don't weaponize the use of pharmacotherapy and say, well, you missed an appointment, we're going to cut you off, or this or that. So you really have to look at each patient individually and decide whether the pharmacotherapy is making things better or worse. So real quickly, I'm going to talk about Haight, the Haight Act, which prior to COVID was really a big stumbling block on our ability to use telehealth to reach underserved or distant areas. Haight was a young man from the West, not Midwest, but Rocky Mountain West. I think he was from Utah, and he died of an overdose of Vicodin. He was able to get these medications online, and we called these online rogue pharmacies, where you could actually, this was back in the early 2000s, you could actually go online, fill out a form, a pharmacist and a doctor would kind of look at it and approve it, and they would send pills to your house. And that's how he got his medication. His family, responded to his death by pushing Congress, and got support from a variety of people to try to tighten things up. So what was passed was something called the Haight Online Pharmacy Consumer Protection Act in 2008. And the purpose of the act was to regulate online internet prescriptions. It's enforced by the DEA and imposes rules around the prescription of controlled substances through telepsychiatry. And when we talk about telepsychiatry prior to COVID, we're talking about live interactive video conferencing. Not telephone, not email. We're talking about where you're talking to somebody through a computer, you can see them and hear them, and it's in real time. So the Ryan-Haight Act, the bottom line is, if you go down to number 4, we can kind of skip the rest. You're doing your regular medical treatment of a patient, but there's the 4th one says you have to do the first one in the physical presence of the patient or the practitioner, which basically defeats the purpose of telemedicine. If somebody lives far away and you have to see them once, then how are you going to do that? It just really, so people were not actually doing this kind of work with controlled substances because that was impeding our ability to do it. So let me see if I have. So I'm going to jump here and then go back, but there were 7 different exceptions that allowed you to do this. One was if you were in a DEA registered hospital or clinic, if there was another DEA registered practitioner there, which really didn't make sense because there was another practitioner there, they could do it themselves. The VA, the Indian Health Service had an exemption. If there was a public health emergency, which now happened with COVID, that was another exception. And then back in 2008, the DEA was supposed to come up with a special registration that allowed individual practitioners to apply for and use prescribed controlled substances through video conferencing. It never happened. And I'm going to go back to this slide because in 2018, 4 rural senators, including the 2 from Alaska, pushed for a special registration for telemedicine due to the opioid epidemic. And it required the DEA to finalize regulations for this special registration with a deadline of October 24th, 2019. And it never happened. So that never was done. So up until March, we were sort of in the same pattern of not really being able to utilize telehealth to expand our ability to reach patients that needed treatment, and there were no providers there. So end of February, due to COVID, these changes occurred. All the Ryan-Haight regulations were suspended. So what that meant was, not only is there not a requirement for in-person evaluation, but in the state of Maryland and many other states, you can actually do evaluations over the phone. Then Maryland Medicaid reimbursement allowed us to work from our homes and treat patients in their homes, which was a change. And the Office of Civil Rights, that's a U.S. agency, said they would not impose penalties for noncompliance with HIPAA rules in connection with good faith provision of telehealth during the COVID pandemic. And I think the reason for that was things happened quickly with COVID and people needed to really scramble to be able to take care of patients. And we were in a better position because we have been doing this, and I'm going to talk about that now, for 5 years. But for people that were just starting, they didn't really have the infrastructure built up yet. So our model that we developed starting at the end of 2015, when a colleague and I were approached by a treatment program in Hagerstown that had lost their provider, was we developed a relationship with a rural treatment center in an area that needs a prescriber. We ran into some problems early on because we were a little naive and didn't know really that Ryan-Haight Act as well as we should. And we learned that we needed to get DEA certification of all of our programs so that we could have one of the exemptions. And that's another whole story. But we were actually very fortunate to work with a great DEA agent, regional director, who helped make this happen. And we were like one of the few regions where this was happening. So other people were asking us, well, how did you do this? As we started to publish data about what we were doing. And when they would talk to their DEA office, they would get a different interpretation of the rules. So at the present time, the way we operate is all of our patients that receive medication-based treatment by telemedicine are enrolled in a treatment program. So they have a counselor. We're able to get urine toxicology screens. We have standard operating procedures focusing on how we clinically communicate. And we found that having a program coordinator at the originating site, which is the program site, is critical in keeping things organized, making sure patients are taken care of and prescriptions are there when they need to be. So this is a map of the areas, the counties that we've worked in up until now. We were in Garrett County. We had a grant to work there. That program was successful, but it's not funded anymore, so it's closed. Washington and Frederick County, we work in there, and the rest of our work is being done on the eastern shore of Maryland at this point. So we have partnerships with rural health departments, including Caroline County, Garrett counties. We did have one with Caroline County's Health Department. And I'm going to talk about the Eastern Shore Mobile Care Collaborative, which is through the Caroline County Health Department. We have work with the Wells House and the Gale House, which are outpatient IOP transitional housing programs in Frederick and Hagerstown. And we work with a rural nonprofit outpatient practice, Life Energy Wellness Clinic, which is in Talbot County, Maryland. So one of the things that we learned was things were a little bit different. I'm used to running my own programs, being the medical director. In some of these, in these programs, I'm a consultant. We had to kind of we had our philosophy, and our philosophy didn't always meld with what was going on in the treatment programs. I mean, we felt, my colleague and I felt very strongly that this was a critical work, that we needed to get people on medicine because it was life-saving, but there would be times where we were working with counselors or treatment providers that had more of an abstinence-based philosophy than we did, and would terminate patients for missing groups or meetings. And I understand there were programmatic issues that were important, but as a physician, I had a relationship with a patient, and to cut somebody off from what I consider life-saving medication was problematic. So that was one issue that we've worked out, and we did that by having team meetings and kind of working through things and talking about treatment strategy. And some patients can present challenges, and we did address those as well. Clearly, there are geographic issues. I found it was very important for us to be able to go visit the programs episodically and to cement our collaborations and develop personal relationships. Some of the programs were not outpatient programs, so what would happen to patients at the end of treatment, we had to work that out. Again, sometimes people would be gone, before we knew it, for a variety of reasons. Sometimes for rule violations, sometimes they had to leave for a family issue or job issue, or they would go across the border to West Virginia or Pennsylvania. How would you address that? We had electronic medical record issues, looking at both the originating and distant site, trying to meld how would we communicate our records and make sure that everybody had what they needed. Coordinating with other providers in the area could be challenging. And just making sure it took us a while to figure out how to do the scheduling appropriately. With the way we did buprenorphine, if you look at the initial regs or guidelines, not regulations, but guidelines, it's recommended that you observe inductions. We've gotten away from that, where we now prescribe, and the patients, we give the instructions and they induce themselves at home. And I think that's actually better for many patients, especially now with fentanyl, which has different pharmacokinetics, and we've seen more precipitated withdrawal. So patients seem to usually have a good handle on how they need to medicate themselves and when, with the guidelines that we give them. and we have we've developed SOPs for all of our programs, which allow sort of clear communication between us and the programs. So we did do a study and this is now expanded. I don't have the newer study written here, but we looked at our first 500 patients that we saw at the Wells House. And that's the demographics, young, more male, because the one program is mostly male, mostly voluntary, and most had a history of injection drug use. And we saw that about 50% were retained in treatment on site at 3 months. And we thought that was actually low about as far as how people were doing, because there was a fair amount of patients that had to leave for reasons that were not related to doing poorly in treatment, that they had, as I mentioned before, family obligations or job obligations, and they would leave and continue their treatment elsewhere. I wanted to talk a little bit about our Eastern Shore Mobile Care Collaborative. So I think it's about 3 years now. We received a grant from HRSA, support from the BHA, the State of Maryland's Behavioral Health Administration, to help us buy the van, and work in collaboration with the Caroline County Health Department. We were already doing direct telehealth into their health department, but we had found that even in Caroline County, which is a small county geographically, that many patients could not make it to the health department for treatment. So we came up with this plan. Initially, we were going to try to find people that had recently overdosed, and but ultimately what we decided was the best thing we could do was park the van in a different small town a different day of the week. And the van does not have a provider, a prescriber on it. It has a peer recovery specialist who is also our driver and mechanic, and we have a LPN on the van and a counselor on the van, and then we have telehealth equipment in the back. So the van will park in different towns, and here are the actually four towns. We've shifted a little bit because of COVID. So one day of the week we're in Denton, one day of the week we're in Greensboro, Ridgely, and Federalsburg. And we park the van there around noon. We have scheduled appointments. We also take walk-ins. And what would happen was the counselor would do whatever needed to be done to get the person their intake. We would get a urine, and then I would come in on the screen and see the patient. We developed relationships with the pharmacies. Since we started the program in January of 19, I think we've seen over 150 patients. It's amazingly busy, which is actually kind of frightening, because these are small towns. Like I do the work in Federalsburg on Monday afternoons, and I'm busy. I'm seeing like 8 to 10 patients a day. And we found that we were saving individuals a lot of travel time. And I guess, you know, I'm an urban person, so I hadn't done that much work in rural areas, but it was really eye-opener about how much transportation is an issue in these areas. That to get from Federalsburg for Denton was just impossible for certain patients. So that's the this is the van. You can see on the bottom, that's kind of it's an RV that we converted into a treatment center. And you can see in the back, you can see the telemedicine screen. And the connection's good. We have a tremendous IT. I mean, one of the things I did learn was IT is critical. That it's not as easy as putting a couple phones together. That there are times where I have a busy patient schedule and the connection goes down, and I have access to an IT team that can really help me out on this and reconnect. Although if we have to, we can do work by phone. This is the team. The woman on the left is not with the program anymore. Roger is our counselor, is our peer recovery specialist and driver. He's a critical component of the team. He's got tremendous relationships throughout Caroline County. Christina is our counselor, and Jessica is our program director. She's more on the UMB side, but helps keep things organized for us. This is sort of a look at the patients that we've seen over time. You can see new patients sort of fell off during February and March and April because of COVID. You know, it's interesting. We're still open. We've we've got COVID precautions, and we're still seeing patients, and actually seeing patients now that were initially seen in the health department, because we're sort of the only shop that's still open. And then just real quickly before we get to questions, so future directions, we think there's room to expand our mobile program into other counties potentially. One of the things we're not really doing, although we did more of during COVID, is in-home treatment. I think our model works really well in Maryland, which is not a remotely rural state. There's not a place in Maryland that you can't get to a pharmacy or a treatment program. But if you're in Alaska or New Mexico, I think you'd have to think a little bit differently. If you had somebody that lived far away, how would you get a urine? How would they get their medications? Could be a little bit more complicated. I think there's we just got a new grant where we're going to start integrating with emergency departments and EMTs in New Jersey. They actually have EMTs starting patients on buprenorphine in the field for people that have overdosed. There is a role for connecting OTPs and skilled nursing facilities in urban areas. Many of our patients at the University of Maryland Hospital come in and with infections that are related to injection drug use, and they get transferred to a skilled nursing facility, are not in treatment, and things don't go well for them. I think it's real important that this type of work is not abused and not used correctly. So I think we need to be real clear that we need to develop good evidence-based standard operating procedures. We do not want to be the people that treat everybody around the state of Maryland. Our goal is to train providers in the field that can do this, and then maybe we can use this model to provide more supervisory help. And what we're moving towards now is we have a very close relationship with our infectious disease team, and we're starting to actually combine infectious disease treatment with this. Many of our patients have hepatitis C and are not in treatment, and the treatment of hepatitis C has become simpler than it used to be. So we're working on strategies to combine those types of treatments. And I think that's it for me. So I wanted to leave about 15 minutes to see if there were any questions.
Thank you so much for the great presentation. So we will now begin the Q&A portion of this webinar. I want to invite everyone to please enter your questions in the Q&A box, which is located at the bottom of your Zoom window. So the first question is, Dr. Weintraub mentioned that MAT is preferred to be called medication-based therapy. I always thought that studies showed that MAT is more effective when used alongside behavioral treatment. Is this no longer the current thinking?
Yes, especially for buprenorphine, the data is not clear that counseling improves treatment with buprenorphine. Now, that's not to say, I'm not here to saying counseling is not important for individual patients, but if you look at the studies, there's actually a great, and I can share it with you, there was a great summary of medication-based treatment that was written by the National Academy of Science that addressed this issue, and I can send it out. But when they look at studies with buprenorphine and counseling does not seem, in placebo-controlled studies, to enhance outcomes with buprenorphine. Now I know, and I know many of the people here know, that counseling is important for many patients. So I think the reason they changed the name was that people felt like that medication was an assist to the other types of treatment, and they didn't want to see it that way. So in this article, they described that a bit as well. So again, I hope that answers the question. I'm not anti-counseling. In fact, I'm pro-counseling for many patients, but I think where we get stuck in the mud sometimes is that we mandate that everybody needs to get counseling. And there are some patients, and I've seen some patients They get into treatment with medications and they do fine and with minimal counseling. So I think we just have to individualize treatment.
Thank you. In your opinion, what impact does the profit motive have on the delivery of MAT services? In other words, are different outcomes achieved by nonprofit MAT services versus for-profit MAT services?
Not that I'm aware of. The studies that I'm aware of, that's a good question. I've never seen, I don't know if I've ever seen a study that compares a placebo, a study that compares a nonprofit to a profit-oriented program. I think there are obviously issues with dosing and how patients are treated, but I think it's pretty clear. Most of the studies it's actually unethical now to do a study with medications like buprenorphine and methadone against a placebo, because it's a deadly disease and it would be dangerous for patients not to be put on the medicine. So I think I need a little more details about what the question was getting at about the profit motive.
Okay, while we wait if there's a follow-up, the next question is, are there published best practice guidelines for MAT programs?
Yes, there are. There's actually federal government, SAMHSA has a program called TIPS, TIP, and they, what is it, treatment, it might be treatment improvement protocols. I should know that, I'm not, but there's probably close to 50 or 60 of them. And one of them is on medication-based treatment. I'm not sure if it's 43. I could look that up and send you the number. But there are many guidelines for this type of treatment.
Okay. Is there a continuum of care specific to MAT services? For example, should communities have methadone, buprenorphine, and Vivitrol options available?
Great question. So I would say yes, if possible. I think probably the hardest, so everybody should have buprenorphine and naltrexone, although naltrexone, the studies have not been as clear about their impact in certain areas, including overdose. But I think patients should have the choice of all three FDA-approved medications. I think the biggest issue with methadone is the way that it is set up now doesn't really allow certain areas to have it because it's so tightly regulated. So it may be that the federal government is going to have to look at different ways of trying to get methadone treatment to more remote areas. I do think there are patients that respond to methadone better than any other medication. And so for that group of patients, it would be nice if it was available. The state of Maryland just passed a law last year. I believe it's HB 116 is the title of it. And in that law, they're mandating that all criminal justice systems or prisons and jails offer all three types of medication. Bottom line is that when people are incarcerated and detoxed and then released, and they're released with no tolerance, in the first 2 weeks post-release, they're over 100 times more likely to die of an overdose than normal population. So what happens is they come out of jail, they have no tolerance. With the lethal fentanyl around, they take it and they die. So I think the answer, theoretically and in principle, yes, all three should be offered and have the continuum of care. I don't know if it's gonna, the methadone piece is, I think, gonna be the hardest the way things are set up now.
Okay. Do you think that the relaxation of the Haight Act will continue post-COVID?
We hope so. So, because this doesn't only not only affect medications for opioid use disorder, but this affects treatment for lots of individuals that can't get to treatment because of COVID right now. And what we've learned is even outside, again, opioid use disorder, they're older and certain types of patients where maybe treating them through telemedicine post-COVID would be beneficial. We were concerned because the last state of emergency was going to end July 25th, and there was a lot of concern that it wasn't going to be renewed, because it wasn't renewed until I think 2 days before it lapsed, and we were planning that we may have to go back to the old way. So there's a lot of push, both locally, statewide, and federally, to try to make these changes permanently. I mean, I think the thing that you always have to worry about is, just like we saw with the prescribing of opioids, that there can be abuses to how this type of work is used. So we just, I've seen it work well. I believe that we do it the right way, but we need to make sure that when we roll this out, that people are doing it the right way if it's going to continue. But I'm optimistic that there will be some permanent changes made.
Great. We received a follow-up on the profit motive question. Is there any evidence that profit-oriented services put profit ahead of patient wellness, or conversely, that profit-oriented services provide higher quality services in order to stay competitive?
I can't answer that question. I think, intuitively, that I know that some for-profits, I think the issue has been that there's been certain programs that have abstinence-based philosophies that don't offer medications because they say you're addicted to another medication, and I think that's malpractice to me, to have a program treating people with opioid use disorder and not offering medications that can save people's lives. I don't know the answer to that question, but it's a great question, and I'll try to look into it.
What schedule do you give the patients for your buprenorphine home induction?
Well, that's individualized. So generally what we try to do is see people within a week when we start them. And generally people probably within the first week get up to between 8 and 16 milligrams of medication. I think that's an average, but we kind of try to judge it individually based on maybe the severity of the habit. Sometimes we'll see people that have actually been off of, we end up treating a fair amount of patients in some of these programs that have been off of opioids for a while because they've been incarcerated. They have a clear, or in hospitals, but they have a clear history of opioid use disorder, and they have extensive cravings and are high risk of relapsing. So it really varies. But generally, what we've done recently is we found that because of fentanyl tends to stay in individual systems longer, that we've seen a fair amount of precipitated withdrawal. And I'm not going to go through the physiology of that. So we've gone a little bit slower and been a little more cautious in getting people started.
How do you advertise the mobile van, and how do you decide where to park it?
So that's really a collaboration with the Caroline County Health Department, and I wish somebody was here with me because I didn't know how they advertised it. They had a campaign, so we did some public relations. It was out in the newspapers. I'm not sure exactly what else they're doing right now. I really took the advice of the local team about where they thought the best place to park it was, and we followed up. So it's really, there's I think 4 or 5 reasonably sized towns in Caroline County, so there wasn't like it was that much choice, and they knew the area and terrain and basically decided where they thought it should be parked. And I think in general it's worked out. Other than I think Ridgely's been a little bit slower and Federalsburg's been a little bit busier. And so for example, there was an area, I can't remember the name, I'd have to pull up the map, but there's an area sort of more north, I guess it would be northeast. Well, anyway, one of the corners of the state where there was a town, but they didn't feel like there was a lot of opioid use there. There was more alcohol, so we didn't go there. So I kind of, like I said, listened to the local team.
Okay. Are your urine drug screens collected by the mobile van personnel, and do you use point of collection urine cups?
Yeah, that's a great question. So they are collected by the mobile van, the nurse, and we do point of care. And we have the ability to send them out as well if we feel like we need to, which we do sometimes, because you can look at buprenorphine or buprenorphine ratios to help determine if somebody's actually taking the medicine, which can help with determining who may be diverting the medication.
Also, somebody asked, why do you collect urine?
That's a good question too. Well, I think it helps clinically to determine how we can titrate the treatment plan. There'd be some people on the real harm reduction spectrum that basically says, who cares? I'm still a treatment provider, and I believe in treatment, and believe that taking most illicit drugs can be harmful. So at least we can have an educated discussion. There are issues at times with diversion, which again, we could have an argument or discussion about whether that's good or bad. I generally don't want my patients diverting their medications. So that you can find that out as well. So I think it's important to know if somebody's using it, can help me dose things different. We can determine if there's other types of treatments that may be beneficial for the patient. Again, we're not rigid and going to force people into things they're not able to do. We're not going to necessarily cut people off medications, but if somebody's actually, actively using large doses of benzodiazepines, it could be dangerous to the patient. So I think there's a variety of reasons to get urine tox screens. I know there's some people that argue that it's, what are you going to do about it? Are you going to kick people out, let people do what they want? But I do still think as a treatment provider, I need to know what's going on with my patients.
Thank you. Could individuals from counties with MAT shortages call a number and be screened and initiate or travel to a van site to launch MAT treatment? In some rural areas, there is a shortage of access to MAT providers.
Sure. I mean, so I don't want to speak too much for the health department, but we do take people from other counties. So I treat people from Queen Anne's, and I mean, I think the issue becomes travel. How far are you going to go to get to Federalsburg, Maryland? So this just speaks that we need to really increase access for other people. But there is not there's not a residency requirement. There would be you would have to become part of the Carolina Health Department treatment program, but you wouldn't necessarily have to live there.
Next question, can you please expatiate on integration of telemedicine with the emergency department? Are you implying that you transition a patient to telemedicine immediately after ED discharge?
Yes. So one of our other things that we developed here in Baltimore was getting people started on buprenorphine in the emergency room. I'm actually ran the psychiatric emergency room at University of Maryland. I saw that many patients came in because of their opioid use disorder, maybe saying they were suicidal, but it was more related to their drug use, and saw that if we could get people started on buprenorphine or whatever a medication was appropriate in the ED, and there's some literature that suggests this as well, that they're more likely to follow up with treatment. So we have actually developed a relationship with Easton. So all the emergency rooms on the upper Eastern Shore, mid-shore area are UMMS hospitals, so I'm connected with them, and I actually have a relationship with somebody in Easton who will call me. He will start somebody on buprenorphine. I can actually review their medical record because it's part of our hospital, and then I get them an appointment, or I actually prescribe for them and then get them an appointment in our telemedicine program. So the answer is yes, and we just got funded on a grant that I'm a small part of that is going to expand that work in those counties. It's a HRSA grant. So yeah, I worked. The other thing I didn't talk about was we also got a foundation grant to do this in the criminal justice system and the jails of Caroline, Dorchester, and what was the other one? And Talbot County. And we just saw our first patient yesterday. So patients that are screened positive for opioid use disorder then are able to get started on buprenorphine while in jail.
Great presentation. Thank you, Dr. Weintraub. Are you only able to offer buprenorphine via telemedicine, or are you able to offer naltrexone and methadone as well?
We can do naltrexone. We cannot do methadone. Methadone has to be I don't know what the right term is, delivered through an opioid treatment program, which is a special program that needs that has to meet certain federal requirements. And as I had mentioned before, there's only 3 on the Eastern Shore of Maryland, 3 or 4 that I'm aware of. So I cannot do methadone. I can do naltrexone and Vivitrol, which we do a little bit of.
Are there any telemedicine best practice models for low barrier, low threshold prescribing?
Yes, I can't go through the whole thing, but there's articles that are written. Again, if somebody wanted to reach out to me, I could find the literature for them. But there are. I actually just saw a review of a low barrier program just recently. I just can't remember where it was, but I could dig it up probably pretty quickly.
As the pandemic has dragged on, are you seeing impacts on numbers or circumstances of people seeking treatment in either the rural Maryland or Baltimore City programs?
That's a great question. So the literature is suggesting that opioid rates are up, overdose rates are up. I think initially people were scared and were not coming out. We're starting to see a return to more normal numbers. I wouldn't say significant increases. I think where I'm starting to see more issues are in emergency rooms, and a lot of it's, I think, with younger folks that I think they're being particularly hard hit by the pandemic because some of their normal activities are being disrupted. So I'm even talking about late teens, early 20s. But I can't say that because we have a big medication-based treatment program in Baltimore City. We're steady, but I wouldn't say that we have had a astronomical increase in numbers either there or in the rural areas.
I am a big fan of buprenorphine. That being said, what could be the downside of massive uptake of buprenorphine treatment with huge expansion through telemedicine?
I think that's another great question. I think it's a great medicine. I think it's really safe. I think the downside would be that people that don't need to be on it get on it. I've had people show up at our programs and we can't figure out, and there's that when we kind of really do a deep dive and a good evaluation, they're not addicted, they're not dependent on opioids, and so you don't want to have people seeing patients for profit just to have them come in all the time to make more money and get people sort of dependent on a medication like buprenorphine that really didn't have an opioid use disorder. I mean, I think there's a chance of, there's always going to be diversion of any of these medications. It's just, there's nothing you can do to totally eliminate that. You can work to minimize it and mitigate it. So there could be a lot of increased diversion, but the question is that really bad if it's going to people that are, there's some literature suggests that most of the people that use buprenorphine illicitly are not getting high, but treating their withdrawal. But is that preventing them from seeking treatment? But then some people would say, well, that's okay as well. So I think in general, buprenorphine is a much safer medication than methadone. It's much less, you're not going to overdose from it. Even though it's safer if a kid were to get a hold of it or a child. So I may be missing something, but in general, I think we just got to make sure we get it to the right people is what we need to do.
Have you found urine testing is necessary with telemedicine? Do you find risk assessments change at all when you are not seeing the client in person?
No, I think in our system we have. So I would say we're very fortunate. I have really great technology. So I would say, it's 80% maybe of being in person. So I get a pretty good handle. But I also have the advantage of having people on site that are seeing the patient, and they can kind of clue me in if I'm missing something. And we'll have a discussion. I'll say, how do you look today? Or, I was a little concerned. I think where I have more trouble is when I have more complicated patients. So I'm treating somebody now that's quite ill psychiatrically, and it's a little bit tougher for me to operate. But if I don't treat them, nobody's going to treat them. So I'm doing the best I can. The other area where I think it's a little bit more complex is I don't really prescribe benzodiazepines for my patients. But there are a fair amount of people that have ADHD, and how do you sort of navigate that space through telemedicine when you're doing opioid treatment is another question, because I just don't always have the bandwidth and time to probably do it the way I'd like to, although I do believe that a lot of these patients I'm seeing probably do have ADHD. So that's those are the patients that I have more difficulty with. I think our philosophy is trying to get people on this medication if we can, if they have opioid use disorder. But like some of the more complex, like I said, psychiatric problems that I'm asked to treat, especially more now with COVID, because a lot of the clinics are either closed or not taking patients, or make it a little bit more problematic.
Thank you. Are there any additional medications that are in currently development that look promising?
Probably, but I wouldn't. They were looking at a vaccine, which I haven't heard much about lately. I'm not aware of anything that's close to coming out. The different formulations of what we have, but there are articles about different types of mechanisms that should be studied that could impact opioid use disorder, but I don't know of anything that's in actual testing right now. But I could be wrong. There may be something that I'm not aware of, but I yet haven't heard from my colleagues.
How do you handle MAT patients where there is evidence of diversion?
I talked to them about it, and we have like a 3-pronged strategy. We observe urines. We talk to them. We ask them, we might shorten the amount of medication that we give them. And then we also ask them to bring their packs back as well. And we look at their urine to see their buprenorphine or buprenorphine level. So we can identify some people. Look, it's going to be impossible. I can't tell if somebody's getting 16 milligrams and only taking 12 and selling. There's just nothing I can do about it. So we talk about it. I think the concern is that you just don't want it to get into the wrong person's hands. If a kid were to get it, a child were to get it, where it could do harm. So we do our best. I have to be honest with you, the team on the ground, and I'm thinking more now, just Caroline County, because that's where I think my most intense interactions with the staff are. They're very concerned because they don't want our program to get a black eye and be known for, just giving out medicine that's being diverted. So we do the best we can. I don't know if that was helpful, but those are the kind of the strategies we employ. And I will talk to patients about it.
Thank you. We have time for a couple more questions. What is your determining factor for referring someone to a methadone program if the maximum buprenorphine dose does not stop the illicit opioid use?
We do refer people. Some people seem to do better on methadone or an agonist treatment, so we will refer out. I think the problem that we have is that people can't get there. So I've had people come, it's usually the opposite, where people are coming from methadone because they couldn't get on a stable dose because they kept missing dosing because they couldn't get there. So that would be one issue. I think diversion would be another issue, that if I felt like somebody wasn't able to take their medicine correctly, consistently, that's another option, because you can actually, not only can you give methadone in an OTP, you can give buprenorphine in an OTP, but you can be observed more closely. So those would be a couple reasons, but there does seem to be a group of patients that don't do as well on buprenorphine and need methadone. Again, the problem is that if you live in certain parts of at least the Eastern Shore, and that's true for Western Maryland too. When I worked in Garrett County, I think the closest so I worked with a clinic in Oakland. The closest OTP was in Cumberland. And that's a pretty good distance, especially in the winter. So there may not be an option.
What is your percentage success rate with buprenorphine treatment compared to other MAT?
So generally, the studies, and I would have to look at our actual numbers, but the studies would demonstrate that people tend to be retained a little bit better in treatment with methadone than they do with buprenorphine. So in the course of a year, and these are just guesses, it might be 70 to 75% on methadone to 50 to 60% on buprenorphine are still in treatment. So they're not far from being perfect medications. And again, I'm not anti-treatment or recovery, because I think those things are really important. I think the medicines help you get started and stabilize your brain chemistry and allow you to take the next step. Some people seem to get it right away and you never see them again. They're working hard, and other people need a lot more support and guidance to take that next step.
Who owns the medical record, the organization you are working with or your practice?
So I think it's split. I own my notes. So we're actually using our electronic medical record to do our notes, and we register patients in our through our registration process, but they own their counseling notes and so whatever they're doing down there. But doctor notes are ours, but we have a release of information. We developed a series of releases of information, and we share our records with them. So I think they're probably faxed at this point. I don't know. I don't deal with that. So, but I know that I can get my notes are mine, our organizations.
Okay, thank you. With that, we're going to end the Q&A portion of this webinar. There were still some questions, but we will follow up with those after the webinar. I want to thank everyone so much for attending. We hope to see you in any of our future webinars. And thank you so much, Dr. Weintraub, for this great presentation and great Q&A session. And I hope that everyone has a great rest of their day.
Thank you. Take care.
Thank you.